Greetings everyone, we're on the diabetes mellitus chapter. So remember, diabetes mellitus is the official term, but we are going to be looking at different types of diabetes. So you're going to be specifically interested in the different types and associating those names with how they are each unique in some respect. And at this point, you should be able to reflect back on things that you've learned in previous chapters and really begin to feel like you're connecting many of the dots. So as we begin a review of this chapter, the did you know points are highly relevant and rather profound, so be sure you take a few moments to copy those down. Examine these key terms. Ask yourself, is there anything here that you don't already know? And if so, take a moment and look it up because they're all going to be relevant. I want to draw your attention to this first section for a moment, and I want to point out to you that really what we have going on in the case of diabetes is a multifactorial state, right? Much like everything else, nothing is simple and straightforward. So I know that most people you meet probably think of diabetes as high blood sugar, but what you have to remember is that it is metabolic abnormalities, and therefore the glucose levels are really out of control, period. They can swing both too high and too low, and they are equal points of consideration. So if someone is not properly managing his or her disease, then there can be erratic highs and lows or abrupt highs and lows. When the blood glucose levels are high, they may not always be consciously aware of this problem, which is really the issue because it wreaks havoc internally and it doesn't manifest in obvious ways until the damage is so extensive that it becomes obvious. Whereas when the blood glucose level drops too low, there are overt signs and symptoms, including someone potentially reaching the point of a coma. So you want to keep in mind that it's not just about high, it's about irregular blood glucose levels. And so things have to be done to manage it at both ends of the spectrum. Now, the person with diabetes mellitus is going to have either a decreased production of pancreatic insulin or no production at all. Remember, the pancreas is one of the accessory organs that are aligned with the GI tract. The pancreas has many different roles. One of its jobs is to secrete certain digestive enzymes, such as lipase, to break down fats. But that's not its only job. It has a bunch of different parts that do different things. And a small portion of the pancreas produces insulin. If that section of the pancreas is not functioning or is damaged, then insulin production is impaired. Now, glucose intolerance or high blood glucose is going to be the result, and so the clinical term for that is hyperglycemia. So how do we diagnose diabetes? Well, your book doesn't speak a lot to hemoglobin A1C, but perhaps you have heard of that. You all know what a hemoglobin is, most probably at this point, which is actually a protein molecule. So when we think in terms of hemoglobin, you're generally thinking about oxygen or iron attached into hemoglobin, hence how those things are transported through the blood. So when you think of a red blood cell and you think of it being red, that's the hem portion. So when we think of hemoglobin, we don't all naturally think about the fact that glucose binds to it as well, or at least some residual component of the glucose circulating in the blood does. So the fascinating thing about this is that the half-life, how quickly the cells die off, is about 120 days, so 90 to 120. So as a rule, if we measure what is called a hemoglobin A1C, a very specific blood test, every 3 months, roughly every 90 days, then it's kind of like we're going through a file cabinet. So I want you to, for a moment, imagine that someone checks his or her blood glucose level 10 times a day. At the end of each day, he adds up all those values, divides by 10, and gets a daily average. Slips that into a file folder and puts it in a file drawer. So every single day throughout the month, the daily blood glucose levels are averaged. Then at the end of the month, that is averaged into one number for the month. And this occurs times 3 consecutive months. That average outcome is the equivalent of a hemoglobin A1C. So it's essentially a 90-day average, which is much more meaningful than any one blood glucose in isolation. It is then converted into a different type of number. It's not going to be the same like 126 or 320 for a blood glucose. It's going to be given a numeric value such as 5.6 or 7.0 or 9.2 and so on and so forth. And what we do when we are trying to diagnose diabetes is obviously we can look at the immediate fasting blood glucose. And if it is above 126, then that's a point of concern. The hemoglobin A1C is, for all the aforementioned reasons, considered to be a much more reliable indicator. Now, keep in mind that, as with all blood tests, one abnormality does not definitively determine anything. There is always room for error. Fluky things happen. So anytime we're using a diagnostic measure of any kind to try and diagnose diabetes, one abnormal value has to be considered potentially indicative, and then it needs to be confirmed by being checked again. So two simultaneous abnormal values are certainly confirmation of the problem, and therefore a diagnosis can be made. I will tell you that physicians are discouraged from using regular fasting blood glucose level as anything but a reason to go a step further and use hemoglobin A1C, which is more of a gold standard. So as you are looking here towards the bottom, the incidence of type 2 diabetes is increasing. And in fact, it is estimated that 415 million people have diagnosed or undiagnosed diabetes. In other words, there are a lot of people walking around with diabetes and they don't even know it. Now, if you stop and ask yourself, why is that? Well, there's one very obvious reason. Many people never go to the physician to get an annual checkup. In my career, with all the people diagnosed with all kinds of health problems, I find that the larger majority of them are surprised that they have some sort of an intense state of illness because they weren't aware that anything was in progress over the years, simply because they say, oh, I didn't think I was sick, so I never went to a doctor. That mindset of we go when we're sick is part of the problem, and hence that's why there is an ever-growing movement towards prevention, because if we can get people to engage in regular self-care, getting annual blood work and physical exam, and that includes well-woman exams beyond that, then we can intervene early and delay or prevent the onset of our most common health problems in this country, including cardiovascular disease, diabetes, and even some cancers. So when you look over here, you see that there are actually 4 classifications. We've got pre-diabetes, which is not actually a form of diabetes, but it is a state that is indicative of the future development. In other words, the train is headed in the wrong direction. This is a red flag. Hey, now's the time to throw this in reverse and prevent the problems. Type 1 and type 2 are the ones that we're going to focus on primarily here because they are those most prevalent within our society. And then there is gestational diabetes, and hopefully you think of the period of 9 months of gestation, pregnancy, when you see that term. Now, there are a couple of references to other forms of diabetes that are incredibly rare throughout the book here, so I'm not going to put any emphasis on those, but that doesn't mean it's not useful information to file away in the back of your mind. So it tells you here that these classifications and the corresponding names have been changed several times. And here's kind of a brief overview. Ultimately, we thought that type 1 was unique to children. We began to see that sometimes it manifests later in life, and we realized that that is probably because in some people that autoimmune condition either progressed very slowly or was not developed and did not kick in, so to speak, until a later time. but as a rule, younger is going to mean childhood. Those individuals are certainly dependent upon insulin, so we decided since it wasn't always just children, we couldn't call it juvenile onset anymore, so we began to call it insulin-dependent diabetes mellitus, IDDM. However, because some of the people with type 2 diabetes, which is the type that is more lifestyle related, it's kind of the intersection of biology and environment, because many of those people have not managed their illness well, and ultimately it progresses to the point that they too must use insulin, then we realized we couldn't call one insulin dependent and the other not, because both could potentially be. So while we were referring to that which necessitates insulin from the get-go as insulin-dependent diabetes mellitus, and the other option as non-insulin dependent, we realized can't use those anymore. So it is now type 1 and type 2. Now, prediabetes is what we looked at briefly in the previous chapter. You learned about the metabolic syndrome, which is a cluster of metabolic abnormalities. Obviously, if the body cannot metabolize glucose properly, that is an error in metabolism or a metabolic impediment to proper glucose utilization. So when we talk about metabolic abnormalities, then the body's failure to use glucose properly certainly qualifies. When we talk about lipid abnormalities, that is the case as well. So I explained to you before that metabolic syndrome, while it was being used in your book to reference the casual phrase precardiovascular disease, it is equally appropriate to be utilized as a term referring to prediabetes. Prediabetes is not an actual clinical term that can be written in a chart or coded for, but metabolic syndrome is. So please be sure that you skim through this section and feel comfortable with the content, and you will find some of what you're looking for in this section as well. So again, although there are several causes of type 1 diabetes, we're not really sure exactly what is going on, but what it seems to be by and large, the primary point of agreement is that this condition is probably an autoimmune disorder, that something has triggered the body. Perhaps it was an exposure to a virus or something. It could have been while we were in utero. It could have been once we were in this world. No one is sure. But they think that we have been exposed to something that for some reason has biologically triggered a response in our body that really shouldn't occur. Our body is thinking it should defend itself. It is identifying something normal as being abnormal. So in this case, it appears that it may be identifying the pancreatic cells of its own pancreas as the insulin producing cells of the pancreas as a foreign entity and destroying them, in which case they can no longer produce insulin. There is speculation as to other causes, but it is not highly agreed upon, so I don't want to cause any confusion and get into that. But I will say there's evidence to support other potential etiologies that are even mentioned here briefly in your book. So when you're looking at someone with type 1 diabetes, remember their body is not producing insulin, and that means it is desperate for fuel, in which case, what's it going to do? It's going to eat itself, right? So think about this logically. If the insulin doesn't exist, then all of the carbohydrate in our food, which has been digested and absorbed into the bloodstream, is sitting there in the blood. Glucose is just building up every time more food enters the body because it has absolutely no way to get into the cells, because insulin is the key that opens the door to those cells, and the key is missing. And so if that is the case, the body says, my gosh, I need fuel. I'm going to have to resort to plan B and C, which is to break down body fat and to break down body proteins that make up organs and skeletal muscle and otherwise, and convert those substrates into glucose so that I will have fuel. So the person begins to lose weight very rapidly as the body consumes itself. In addition, the body is desperately trying to flush out these high levels of glucose in the blood. Urinate, urinate, urinate. Of course, the more the person urinates, then the thirstier they are going to be, and they're going to drink more and drink more and drink more. And if your body is eating itself because it feels like it's starving, then you're going to feel hungrier and you're going to eat more and eat more and eat more. So this cluster of signs and symptoms is usually the telltale indicator that what is occurring is a rapid onset of type 1 diabetes. It's not a difficult diagnosis to make. As you look through here, type 1 diabetes must be treated with insulin, and modification of the patient's diet is also necessary. Remember, any kind of nutrition therapeutic intervention is called collectively medical nutrition therapy. So registered dietitians, like myself, practice medical nutrition therapy, MNT. We use diet as a medical form of therapy for various conditions, prevention and treatment, both. So when you look here, you're going to see some of the explanation of how the insulins can be used. And in today's world, I will tell you that there are ever evolving brands and forms and methods of administration far too complex for our purposes in this one course. But ultimately, most people will be giving themselves insulin at the point of meal consumption because they need to be able to match that insulin to what they're eating. Remember, when the pancreas is fully functioning and a person eats, the pancreas responds to the presence of carbohydrate in the intestines and it releases insulin. As the carbohydrate is absorbed into the bloodstream, the insulin is matched such that it helps to adequately pull the glucose into the body cells, allowing the levels in the bloodstream to go back down. Well, in order to mimic that or replicate it, an individual with type 1 diabetes must simply know how much insulin his or her body needs upon a consumption of a specified amount of carbohydrate. So it doesn't matter how much carbohydrate that he or she consumes at a given meal, nor even where it came from. What matters is that the person is able to give himself the appropriate amount of insulin. And that takes a little training and practice. As your book explains, it requires eating and recording blood glucose levels for a couple of weeks, and then also recording everything that's eaten so that the average carbohydrate content can be determined, and then we can see how much insulin works for the person. So we usually will start at a baseline of saying for every 15 grams of carbohydrate you consume, you're going to need 1 unit of insulin. We will then teach the individual how to quickly assess foods. We will say, for example, that 1 serving of fruits is always about this much and contains 15 grams. 1 serving of milk or dairy is about this much and contains 12 grams. Meat contains 0, and so on. It gets to the point where a person can look at a plate of food and very quickly estimate how many grams of carbohydrate are there, and then quickly estimate how much pre-meal insulin will be necessary. And as this goes along, a person gets better and better at it. And this way, too, as their body changes physiologically due to age or disease or changes in lifestyle, then they can reassess things and adjust their insulin dosage up or down as necessary. It's just simply a way to try to work with the body to try to match everything and recreate the previously normal state. Again, this is for type 1 diabetes because it's absolutely necessary to use insulin. Now, when you look at type 2 diabetes, the manifestations are much slower. In fact, by the time a person is diagnosed with type 2 diabetes, it's usually been about a 10-year period over which time metabolic syndrome was taking place and progressively worsening. And again, this is oftentimes because people either don't go for a regular checkup or they go very sporadically. Maybe they went 5 or 6 years ago, told everything wasn't too bad. Even if it was abnormal, they didn't think, well, it's not that it was too serious. They thought it's not that bad, and they really didn't address it, and now it's grown by leaps and bounds. So the value of going every year is not just to see where someone is in the moment, but to be able to follow the trend over time, because if it's headed in the wrong direction, if lipid levels are ever increasing, if blood glucose levels fasting are ever increasing, if waist circumference is increasing or excessive, if blood pressure is increasing, then all of these things tell a story. They give us a forecast for what's to come. So read carefully here on these pages and identify the specifics, and then you segue into gestational diabetes, which I mentioned at the beginning here, and I provided on your hard copy an additional link for you to visit so that you can understand what was not explained here in the book, which is really quite important to know. As you continue on, we're reading. We look at the actual metabolic processes. So I'm not going to go through everything here. What I really feel is important is carbohydrate metabolism. And so I'm going to open up and go through a few slides, then I'm going to skim back through here. So that being said, let me open up these slides, some of which you have seen before because they were appropriate then and they are even more appropriate now, and then a few additional slides. So let's check your knowledge. Hopefully you're going to watch and listen and think, yep, I know that. Yep, I got that. So first and foremost, we cannot lose sight of the fact that carbohydrates are the body's preferred and primary fuel source. Remember, the body prefers to use carbohydrate first and foremost. Fat is plan B. And the idea is to get enough carbohydrate to spare protein because protein has so many other valuable functions in the body. However, it does contain a caloric component, and those calories contribute fuel to the body, and it can be tapped into even more so as a last resort. So again, what we want with people with diabetes is for their tank to neither be too full nor too empty, because their body can no longer regulate that for them. So it's going to take a combination of physical activity, dietary management, and or pharmaceutical interventions, whether that means oral medications or insulin. So first things first, I told you previously what is not correct. I told you there is no food group called carbohydrates, and hopefully you feel like that's second nature now. You know that carbohydrates are one of the 3 macronutrients, and that all foods except meat and eggs contain carbohydrate. I told you that it is incorrect to say that all sugar is bad for us, because all carbohydrate containing foods are going to be digested, and the components that are digestible, which means the glucose and or rather the sugars and the starch, become glucose, whereas of course the fibers are non-digestible. So all of those carbohydrates that we are able to process and absorb become blood glucose, or what people casually term blood sugar. So we need that. We need carbohydrate. The problem is not that it is sugar once it's in our body. The problem is where it came from originally. And if it came from within a whole food, fruits, vegetables, nuts, seeds, dairy, whole grains, beans, then it was packaged along with a wealth of other valuable nutrients, and it is diluted within those. But if it is pure sugar because it has been added to something in some way, then it has no other value whatsoever, and that's the sugar that all of us, diabetes or not, need to limit for a multitude of reasons. I pointed out to you that sugar does not cause diabetes. So now let's review that. Type 1 diabetes is presumably due to an autoimmune disorder, something beyond our control. Gestational diabetes, as you'll be reading in the link this week, is a hormonal issue that occurs during gestation. And type 2 diabetes is the manifestation of a multifactorial situation, largely driven by excess abdominal adiposity. In other words, too much belly fat and inadequate skeletal muscle that results from too little physical activity. So sugar is not the culprit. Sugar might be the thing that somebody consumes too much of, and that's what makes them gain weight, but the sugar itself did not directly cause the diabetes. The excess weight is the bigger factor, and excess weight can come from many other things, as you know, other than sugar, including excess protein, excess fat, and alcohol. So you know that all of these foods contain a macronutrient carbohydrate as well as vitamins, minerals, proteins, fats, water, and phytochemicals. So these are mixtures of nutrients and other non-nutrient substances that have immense value to our health. And most of these things, with the exception of dairy, are also going to be rich in fiber because fiber, as you recall, exists only in plants, and fiber has a multitude of health benefits, including the fact that those are carbohydrate calories we do not absorb, which helps us from a weight management standpoint. So, being that you learned that photosynthesis is the method by which plants capture the sun's chemical energy, and then animals such as ourselves can then acquire what we need to produce cellular energy by consuming the plants, let's remember that ultimately everything becomes single saccharides during digestion, and hence those saccharides are absorbed into the bloodstream. The body at that point has no clue where those molecules originated, whether it was from honey or a Snickers bar or an apple or a carrot or kale, because they are all in their simplest form once they reach the bloodstream. Again, the difference is what came with them. So as these simple sugar molecules are absorbed through the walls of the small intestine and into the bloodstream, it is only natural that the blood glucose levels are going to be rising. They are accruing fuel in the fuel line. And so as this occurs, the body's natural response is to think, I've got to get that glucose, that fuel, out of the fuel line, the bloodstream, and into all of the cells of the body so that they will be able to do the things that they do internally. So your body's natural response to a rising blood glucose level is that the beta cells of the pancreas release insulin into the blood. And the insulin, as you know, acts as the key. And the point of the key is to open the doors of the cell. Now, if you recall, these cells actually have multiple doors. The larger a cell, the more doors it has. The smaller a cell, the fewer. Each one of the doors is accompanied by a keyhole, and you can think of insulin as the key. So that insulin receptor site is essentially a keyhole for the key. As those keys insert themselves into those sites and open those doors, the insulin is able to move into the cell, and hence the blood glucose level goes down. Once inside the cell, all of those amazing metabolic functions take place. This is just a synopsis. I shared this with you before. It's probably more meaningful at this point, so it's something that you might want to pause and take a second to really look at. Also, this is the summary of what I was explaining, so this too is worth a brief pause. Read the points, make sure you feel confident and like you understand all of this. So type 2 diabetes is certainly the most prevalent type of diabetes in our society, and once again I will reiterate that it is largely the manifestation of lifestyle practices. So while there is a genetic propensity for developing diabetes, what that means is that one has genes which are more sensitive to certain environmental stimuli than the genes of another person. So if a condition runs in a family, then what it is a genetic susceptibility. In other words, we and our family are more sensitive to being sedentary. We and our family are more sensitive to accruing excess abdominal adiposity. We and our family are more sensitive to the impacts of high intakes of saturated fat. we in our family are more sensitive to the intakes of high levels of sodium. So those genetic propensities for a sensitivity can only matter if one exposes themselves to the things that are problematic for his or her genes. So if that person chooses to move too little, or chooses to eat too much, or chooses to choose less than healthful choices, then he or she is putting all the puzzle pieces into place such that ultimately, if all the pieces fit together, the end result is the manifestation of the disease. So we wield a great deal of power in terms of prevention over diabetes, specifically type 2, first and foremost, but also over other forms like gestational diabetes to some degree, when we exercise the lifestyle practices that serve a medicinal or therapeutic function. So as the insulin keys are inserted into the keyholes and the glucose is leaving the blood and entering the bloodstream, we are seeing that the blood glucose level is normalizing. That's normal for it to go up when we eat and down when the glucose leaves the bloodstream. So a continuous smooth rise and fall of blood glucose throughout the day is absolutely normal. But if the body experiences insulin resistance, in other words, if the key is unable to insert itself into the keyhole, the cell is resisting the insulin, then we have to ask ourselves why. Why is it resisting the key? Well, the concern first and foremost is that if the key won't work in the keyhole, then all that blood glucose is going to stay trapped in the bloodstream and it is going to wreak havoc on those blood vessels. And damaging blood vessels is an invitation for plaques to form, hence cardiovascular disease. So we have to ask ourselves, not how do we try to treat the problem, but what is causing it? Because if we know what is causing it, then maybe we can fix what's causing it, and that will resolve the issue. Well, again, the larger the cells, the more keyholes and doors, the smaller the cells, the fewer. Everyone knows that when you exercise, muscles hypertrophy. They grow larger. We know that all tissues, including muscles, are just massive collections of cells. So when we use our muscles, the cells expand. Therefore, it creates greater accessibility for glucose. So many individuals with a sedentary lifestyle are at risk for insulin resistance, even, and hear me now, even if those people are of a normal weight or what you might label as thin, because muscular atrophy is a risk factor for type 2 diabetes for this very reason. Now, many times, people who lead a sedentary lifestyle, who don't get nearly enough physical activity, also gain weight, partially due to inadequate activity and partially due to overconsumption of food. So if someone gains excessive weight, that's a double whammy. But we all know somebody who eats as much as they want and they stay thin and they never do any kind of activity. What I'm telling you is that that person is equally at risk. So let's think about the person who has not been blessed enough to eat whatever they want and not gain weight. Think of most people. Most people who don't move enough are going to gain weight for that reason alone, because even if they don't seem to be eating an excessive amount of food, an even normal amount is too much because they expend so few calories. So as adipose tissue accrues in and around our organs in the abdominal region, in the visceral cavity, as that visceral adiposity increases, then it acts as gunk in the keyhole. So if you took a big wad of bubble gum and you stuck it in a keyhole and you tried to put the key in there, chances are it's not going to work. There's too much gunk in the keyhole. Well, that's that belly fat, as we casually term it, and that's why that apple shape is such a concern. If we have a lot of junk in the trunk, it doesn't matter because there's no organs there. What matters is that when our waist circumference grows larger, It's an indication of excess visceral or abdominal adiposity, which creates metabolic dysfunction. And you know that diabetes is a disease of metabolic dysfunction. So what's the pancreas going to do? It's going to say, hold on, I'll make more keys, I'll make more keys, I'll make more keys. Well, think back to what I said. By the time most people are diagnosed with type 2 diabetes, it's been probably something like a 10-year process. So that pancreas has been cranking out as many keys as possible, hoping that one of them will work. For a while, that pancreas might have produced enough insulin keys that it worked. But over time, like anyone or anything, increased production levels take a toll and exhaustion ensues. The organ is going to start to wear out. This is a picture of an exhausted pancreas. So ultimately, when that occurs, then the organ can no longer continue to produce enough insulin to meet demand. So think about it. Type 2 diabetes begins with insulin resistance, which was likely occurring during the pre-diabetes stage of metabolic syndrome, and then during the course of the disease itself, once it has taken hold, the insulin resistance has taken a toll on the pancreas such that insulin production is diminished for good, and there's no real good way to recover from this. And so if we don't manage the condition effectively once we are diagnosed, then the same things that led to it are going to be leading to our demise moving forward. Lifestyle is powerful. So that's how you know that using food as medicine is powerful. Lifestyle, physical activity, sleep, stress management, and eating habits are some of the best tools at our disposal. They do numerous things simultaneously. They are affordable, they are socially acceptable, and they are within our reach. And one of the primary means of therapy for individuals with diabetes, whether type 1 or type 2, is the use of MNT known as carbohydrate counting. As I said before, people have to count carbohydrates. So I explained to you that individuals with type 1 have to learn how to count up the carbohydrates that's in the food they're going to eat. Doesn't matter how many grams there are, they just need to know what they're going to eat and then dose their insulin accordingly because they're recreating a normally functioning body. That's actually the easier way. For people with type 2, though, it's a little bit different. They're going to actually have to be much more careful. Now, both parties, type 1 and type 2, should care about a healthy diet for all the obvious reasons, instead of just eating whatever equals the right number of carbohydrates. But the difference is, people with type 1, there is no limit as to how much carbohydrate they can consume because the insulin compensates for that. In people with type 2 diabetes, the idea is to avoid using insulin. That's ideally a last resort or when the disease has progressed tremendously. That is not good news. So the idea is to use diet or physical activity, and some people do nothing but that to manage their disease, and or diet and physical activity in conjunction with some oral medications, all of which I might add have short and long-term side effects that are of concern. So the more that we can use lifestyle methods like medical nutrition therapy such as carbohydrate counting, the better off a person will be overall. So what I would do if I were a dietitian helping an individual with type 2 diabetes is I would educate the person about healthy eating in general, like what you've learned in this course. I would explain everything in moderation. I would help the person understand that they can still have some treats in life. It's not about deprivation because that's unrealistic, but that they have to always be aware how to manage that. So I want you to think of cough medicine. You've probably taken some sort of cough medicine in your life or known somebody who did. Usually the container comes with that little plastic cup on top. You pour in the allotted amount into the little cup, the proper dose, and you throw it back, and then you wait the specified time on the label, whether it's 2 hours, 4 hours, or 6 hours, and then you throw back that specified dose again. That's what we ask of people with type 2 diabetes if they want to try to use this as a tool to focus on a primarily healthful diet with some exceptions that are realistic, and to manage the amount of carbohydrate they ingest based on their own body's needs, and to do it at regular intervals so that they don't go so long without adequate carbohydrate that the glucose levels fall too low, nor do they eat so frequently or so much at one time that the glucose levels go too high. This isn't something that people learn in a day or two. It's a process. Change is a process. They can go to a course through an approved diabetes education program at a hospital if there is one in the given area, and usually it's a year-long program. It's usually more intensive in the beginning, and then the frequency and intensity weans off. Or they can see a private practice registered dietitian if there is one in the area and take those approaches. The reason I keep saying one in the area is because the Keys are one of those areas that is unfortunately not well tended to. And so we don't have any outpatient diabetes programs nor any private practice dietitians at the present time, um, since I'm not doing that. So it would require going to Homestead or Miami if you live in the Keys. But for people in large metropolitan areas, whether they have private insurance or they have Medicare or Medicaid, the law requires that medical nutrition therapy for diabetes be covered. So let's imagine you're my patient. You have been diagnosed with type 2 diabetes. I've got your height, your weight, your physical activity, and all those things that I need to estimate your calorie needs. And I say your body needs about 2,000 calories a day. That's what it needs to function and to maybe help you lose a little bit of weight slowly. So I say, people need 45 to 65% of their calories to come from carbohydrates, somewhere in that acceptable macronutrient distribution range. So we're going to stay a little closer to the lower end, but we're going to start with 50%, and we're going to see how you do. We're going to have you consume 50% of your calories every day from carbohydrate in the equal doses at each mealtime that's evenly spaced. And you're going to record what your blood glucose levels were so that we can see if this is the right amount, and if not, then we'll tweak things out. So I convert the math, and I determine that based on 4 kcals per gram, you need about 275 grams a day. So I say to you, what do you do? Do you eat breakfast? What do you do? And you say, well, I usually don't eat breakfast, I eat lunch and dinner. And I say, well, as a person with diabetes, you don't want to go too long without food. Going from dinner until lunch is a long time, and you could have hypoglycemia. So we're going to need you to eat some sort of a meal earlier in the day, and then 4 to 6 hours later another, and 4 to 6 hours later another. And so that's going to be a change that's going to be beneficial. So we're going to take that 275 grams of carbohydrate for the day, and we're going to divide it into 3 meals. And as we do that, we figure, okay, that's about 90 grams per meal. So we start talking about what your typical meals are, and you tell me a little bit about what you like, but you're trying to be more health conscious. And so we start looking at examples of meals. And so I say, okay, let's talk about a sample of a dinner. You say, well, I know salmon would be a wise choice. It's full of omega-3 fatty acids. It doesn't have a lot of saturated fat and such. And hey, it has no carbohydrates, so I can have any amount I want, right? And I say, sure, have as much salmon as you would like. And you say, well, I know I need to eat more high fiber vegetables, so I'll have a non-starchy vegetable, broccoli. And I say, well, every half a cup of that cooked vegetable is about 5 grams. So a cup is a pretty reasonable amount. And so you say, well, I'm going to have a cup of raw tomatoes as well. And I say, well, when we cook vegetables, they shrink down. So that's why there seems to be a little bit more of the carbohydrate in the broccoli than in the raw. It's a little bit more concentrated. So it's only about 5 grams in that raw tomato. And then you say, and I love mashed sweet potatoes. Is that okay? I say, of course, that's color, orange. You want bright, vivid colors. There are a lot of benefits of potatoes are high in potassium to help lower your blood pressure. I suggest sprinkle a little cinnamon on them for flavor because they are naturally sweet and it tastes delicious. About a cup, based on 15 grams per half a cup, is 30. And if you're eating whole wheat, then you have room for things like bread. And you say, what about if I want to have a treat? And I say, well, let's imagine a meal where you did have some ice cream. We would have to look on the container, but most ice creams are going to be around 20 to 30 grams per cup. So let's estimate that. And you can see that this person is far from starving or having to eat weird, yucky food. And they have a delicious, beautiful, healthful meal that's very filling and they won't feel deprived at all. And they have met their body's needs in a reasonable way. So you see, there's room for everything with everybody. My favorite thing to tell people with diabetes is that I'd really love to help you understand how you can eat absolutely everything because I feel people never get to hear that enough. And people usually are very receptive to that comment because that is not what they were expecting to hear. So we've come full circle. You know now what is not correct, and you also know what is going on. And of course, you're always welcome to post questions, but at this point, I'm going to go back to the textbook and I'm going to make sure that I've pointed out a few key things. So you see here carbohydrate metabolism and diabetes, and now with the explanation I've given you, I think that it will make more sense to you. I'm going to ask that you look through the fat metabolism and diabetes and the protein so that you can answer the questions accordingly. And then when you get over here to nutrition therapy, what I've just spoken about should ring familiar between what I have shared with you on the hard copy and what I have shared with you verbally here. And I don't know why that looks blurry, if that's just me or if it looks that way to everyone. So the carbohydrate intake recommendations are not something you need to sweat the details about, but as you go through this now, I think it will make more sense since I gave you a brief explanation. And then as we continue over here, you guys all know how to read a nutrition facts panel. So for those foods that don't come with labels, like the ones that were just on the sample there, people need to just know off the top of their head some kind of a conceptual thing. So I will teach them one piece of whole wheat bread is usually around 15 grams. So if you're going to eat a whole wheat hamburger bun, that's like eating two pieces of bread. There's a top half and a bottom half. So how much would that be? 30 grams. If I tell them that 1/2 cup of potatoes or rice or starchy vegetables like peas is 15 grams, and they want to have a cup and a half, then they're able to determine that's 45 grams, and so on. But if someone's going to eat something with a label, then as you learned long ago, the total carbohydrates line is there just for people with diabetes so that they can see how many grams is in the quantity that they will consume. So way back when I told you the only people that ever need to look at the total carbohydrates line are people with diabetes, and now you know why, so that they can utilize the form of medical nutrition therapy called carbohydrate counting. Have I said those two phrases enough now? Because they will definitely be on the test. So continuing on, right down here, take a little look at this. I think it's going to be more meaningful to you. Here's what we're going for when we teach somebody this. What I would tell them is, okay, let's start with breakfast for 4 to 6 weeks. And let's write down your blood glucose 2 hours after you eat. Then we'd move on to doing the same for lunch for a number of weeks, and then for dinner, until we could kind of figure out what works for that person's body at each time of day. Maybe it turns out, for whatever reason, that their glucose levels after breakfast are still too low 2 hours later. Maybe it's because they went so long overnight. So they need more of their carbohydrate at breakfast and less of it at lunch, perhaps. It's a very individualized thing, and it will have to be adjusted over the course of the years because people's bodies change for a myriad of reasons. But in the immediate learning phase, I'll say, hey, let's record everything you eat for a week at breakfast. Then let me take a look so I know roughly how many grams of carbohydrate you're consuming. And 2 hours after you start eating, not after you finish, but after you start, because the moment you start putting food in your body, it starts to be digested. And the end result is absorption of the carbohydrate. So 2 hours after you eat, let's see what your blood glucose is. That's like saying you pulled up to the fuel tank and you drove your car for 2 hours. Let's see where the gas gauge is. Because if that gas gauge is still on full 2 hours later, something is wrong with that car, right? Why is the fuel still in the fuel line? So we want to see what happens over the course of 2 hours. Did we give you too much gas, too much carbohydrate, and so you need less? Or is it surprisingly low 2 hours later, in which case your body's metabolizing it quickly and you need more? So the only way that we can individualize this guidance for people is to assess what's happening in their body, and that requires a collaborative approach between patient and clinician. So if you're thinking right now, yeah, how often does this work? I won't lie to you. People are not very good with self-care, self-management. That's how many of these health problems developed in the first place. And so you can't always expect people to swing to the better end of the pendulum just because there is a problem. Many people experience denial upon diagnosis of various diseases, or depression, which impairs motivation, or have any other myriad of issues, psychological or otherwise, that impair their ability to self-manage. And so these tools are for those people who are capable of using them. You can see more about this here. I'm not expecting that you'll be an expert in carbohydrate counting, nor will you likely ever use it yourself unless you become a certified diabetes educator, which is certainly a role that is open for nurses as well. Usually in that role, nurses do more of the foot care management and blood glucose monitoring, education and such, teaching people how to do those self-care, while the dietitians obviously do more of the exercise and diet component, but both parties have to be equally versed in all components so that they can work well together or cover when the other is not available. I don't expect you to read this glycemic index and glycemic load section because that has been addressed in previous chapters, and hopefully right now you're thinking, yeah, I remember that is not very reliable, so you're welcome to skim it if you want, but it's not a tool that is generally going to be utilized or recommended. I do, however, encourage you to read about the non-nutritive sweeteners and also about fat intake and protein intake, as well as alcohol down here at the bottom. And that in turn takes us to the section on weight management, which is very brief. Skim through that. And then more importantly, hypertension. And I did put a little more focus on that, so please be sure to read that carefully. I don't think that you will be at all surprised at what you read here based on all of the stuff about supplements that has already been addressed, so you can skim through that. But once you get down here to these cardiovascular risk factors, some of this may be a bit newer terminology for you. So try to put your emphasis starting here in this section and continuing through all the way down to this. Now, once you get here, dietary considerations for special populations, I did not ask you any specific questions on these pages. Although that doesn't mean that the multiple choice questions, the case scenarios at the end, might not be applicable. There are several things introduced here, including some of the lesser known forms of diabetes and PCOS. I cannot recall off the top of my head if we're going to address PCOS in a future chapter, but if you don't know what that is, you can Google it, and there is quite a bit of easily accessible and reliable information. It is usually best if you put in polycystic ovary cyst syndrome .edu to try to find, or .org to try to find a reliable resource, of course. you yourself or somebody you may know may suffer from PCOS. It is not at all uncommon anymore. The cultural considerations are really just to kind of lay a foundation in your mind. You're not always going to remember all of the specifics about differences between us. It's more to increase your awareness so that when there are differences among people, you actually think, hey, I need to explore what the differences are. I need to ask this person, how are you doing things differently than I might be doing them? Or do you have any unique needs, concerns, or requests? So that we can be respectful and not give out blanket information that simply is useless to many people. So that takes us, of course, to the chapter summary. And I think that that's just a simple one. I would just glance through that one because I put much more emphasis on your understanding of the larger concepts. All right, we're almost to the end, everybody. Hang in there.